Good morning, everyone. I am Dr. Pulpathirana, Consultant Respiratory Physician, District General Hospital, Trincomalee. My co-chair is Dr. Vatsala Gunasinghe, Consultant Respiratory Physician at National Hospital for Respiratory Diseases, Valisara. And I warmly welcome you all to the webinar on sleep-related breathing disorders organized by the Sleep Assembly of the Sri Lanka College of Pulmonologists. We are delighted to have 6 speakers today who are very familiar with the management of sleep-related breathing disorders and these stuffs. So we will be conducting the session in one stretch. Therefore, if you have any questions, you can send through the common platform of Zoom chat function. Therefore, those will be addressed at the end. So without any delay, my co-chairperson will introduce the first speaker.
Our first speaker is Dr. Samanwali Dadu, Consultant Respiratory Physician, TH Karapitiya. She has been trained at National Hospital for Respiratory Diseases as a senior registrar and had further training at Royal Brompton and Harefield NHS Foundation Trust. So she will be delivering the first lecture of this symposium. Over to you, Samanwali.
Thank you, Dr. Vatsala. Thank you for the college for giving me this opportunity to talk to you about clinical workup of excessive daytime sleepiness. Today my lecture will be on these topics. What does excessive daytime sleepiness? Falling asleep easily and almost everywhere, periods of sudden and uncontrollable sleep or feeling sleepy or drowsy during past month. An individual struggling with excessive daytime sleepiness may complain of one or more of the following. Episodes of inadvertently falling asleep, including sleep attacks, a prolonged main sleep episode that is unrefreshing, recurrent naps in the same day, sleep inertia. That is prolonged difficulty waking up with irritability. Patient may complain of fatigue, which will need to be differentiated from excessive daytime sleepiness. Impact of excessive daytime sleepiness. Excessive daytime sleepiness is one of the greatest challenges faced by modern society. Life has changed considerably in the past century. After invention of the electricity, introduction of artificial lighting, personal computers and the internet, to accommodate contemporary lifestyle and economic demands, the period of wakefulness has been extended at the expense of sleep time. Most healthy individuals require approximately 7 hours of sleep during the main sleep episode to be refreshed and alert during the day. Many people curtail their sleep to meet social, vocational, and economic demands. As a result, many of these people struggle with excessive daytime sleepiness when they should be fully awake. This happens over a period, gradually, unintentionally, resulting in poor insight of the cause and effect. This habit exacts a high price, individually, socially, and economically. Beyond affecting patients' quality of life, mood, and functionality, excessive daytime sleepiness can become a public health concern when affecting critical job holders. Example, major catastrophes happened in the past. Excessive daytime sleepiness contribute to the motor vehicle accident and fatalities each year. Just a few words about past catastrophes happens. So there was a story on Exxon Valdez oil spill where the accident happened 3 decades ago with the oil spill in the ocean. So after what was the investigator conclusions? The captain of that ship was under the influence of alcohol and he was asleep in his bunk during the time of accident. And again, they have investigator also pointed out the captain has made a mistake by handing over the vessel's helm to the sleep-deprived third mate. So with that, the catastrophe happens, and there was a serious mistake happen when the patient feels sleepy, and if the patient is doing a critical job, the results will be very serious. So with that, how are we going to evaluate the sleepy patient? Daytime sleepiness is a subjective individual perception change with the social circumstances. Health-seeking behavior on excessive daytime sleepiness is different in different social backgrounds. For example, a driver might realize it at the onset, but sedentary life person might not. So meaning that it is important to be able to accurately screen and identify excessive daytime sleepiness and provide proper treatment. Having a standard ways in evaluation of these patients is very important. Who will affect with excessive daytime sleepiness? People with insufficient sleep syndrome, inefficient sleep syndrome. Some may be because of the medications, some may be because of the neurological and psychiatric causes. Who should be screened? Excessive sleepiness may affect cardiovascular, neurological, and psychiatric status of the sufferer, leading to increased morbidity, even mortality in severely affected patients. Other breathing disorders such as asthma as well as gastroesophageal reflux disease can disrupt nighttime sleep and lead to daytime sleepiness. There is a debate whether following categories need screening for OSA. Obesity, central body fat distribution, age for more than 40 years, increased neck circumference, nasal obstructions, anatomical abnormalities, whether it's economically, are we to do the OSA screening or are we to do the sleep screening, daytime sleepiness screening? It's still debate. So, in clinical evaluation of excessive daytime sleepiness, start with the history taking. Good history is not going to replace any modern tools. Questions should be open-ended. It's time-consuming exercise. Surroundings should be calm and patient need to be relaxed. Presence of a family member will further enhance the answers. Snoring, witness apnea, excessive sweating, gas arousal, nocturia and choking or coughing while asleep are suggestive of sleep-related breathing disorder. Consider the patient work schedule, shift duty. The use of tactics while driving to stay awake, such as rolling the windows down, playing loud music, snacking, even slapping oneself, are all indicative of excessive daytime sleepiness. Time in bed, sleep hygiene are important aspects. The number of questions used to identify excessive daytime sleepiness is critical because it has many associated symptoms. Involuntary naps, drowsiness in inappropriate or unsafe situations, unrefreshing prolonged main sleep episodes. Those are important questions. Drug history, such as antihistamine, can cause excessive sleepiness. Those are over-the-counter available. The current or past use of recreational drugs, including alcohol, should be discussed. Sudden withdrawal from stimulants such as cocaine or amphetamine also cause significant sleepiness. It is important to distinguish between sleepiness and fatigue. The distinction between the two terms should be explained to the patient. Ask about the sleep paralysis, cataplexy, hypnagogic hallucination, and sleep attacks, which may be a clue for the neurological cause. In addition, the history should include asking about the irresistible need for naps throughout the day and whether the naps are refreshing or not. Physical examination. Start with the body mass index and neck circumference. Examine the oral cavity for the tongue size. Note the presence of narrow arc palate, tonsillar hypertrophy, retrognathia, micrognathia, nasal septum deviation, allergies, nasal polyps. Those are risk factors for sleep-related breathing disorders, which is ENT consultants, OMF consultant specialty. So Mallampathy's classification is very helpful in evaluating airway size. It has been shown that high Mallampathy score and nasal obstruction are risk factor for obstructive sleep apnea. Then once the history and examination finish, we can do the stop bank questionnaire. It has 6 parts. More than 4 is having high-risk patients with OSA. It's suggestive of OSA. What are the subjective measures of sleepiness? Epworth score, Stanford sleepiness scale, sleep diary. Out of these, Epworth score is the commonly used one. It has got 8 situations where patient can mark, depending on how the chance, how they feel, the chance of naps, sleepiness during that occasion. For example, watching television, whether the patient has a slight chance, moderate chance, or high chance. Out of these 8 into 3, if the patient has got 11, that is, start with the more than 11 is significant. And there is a chance of having a sleep-related breathing disorders. Stanford sleepiness scale is one of them. Different tools have different sensitivity and specificities. For example, if the patient is having severe OSA, stop bank has a sensitivity of 95%, but Epworth score has a 79% sensitivity. Specificity-wise, stop bank has a 25% specificity, but Epworth score has 75% specificity. Sleep diary, that is important thing for the patient's history. A patient's sleep diary can give insight into the cause of the patient's sleepiness. The patient is asked to maintain this log for 2 weeks, recording bedtime, wake time, number of arousal, time it takes to return to sleep after an arousal, and any other relevant symptoms. So it's helpful to identify sleep fragmentation, insufficient sleep time, circadian rhythm sleep disorders, and etc. So this is the sample of sleep diary, where that one is filled for example. This can use to see how good the patient sleep during the last 2 weeks. So once the history examination, different questions and questionnaires and sleep diary is filled, we have identified how probable the patient has sleep disorders, breathing, or other sleep disorders. So depending on the pretest probability, we will be either exclude or diagnose the patient's condition. What are the literature on excessive daytime sleepiness? Excessive daytime sleepiness may be under-recognized. A study published in 2019, conducted by Banu and colleagues on US adult population. They have studied 5,962 patients who are more than 18 years old. They examined the prevalence, socio-demographic features, pattern of comorbidity, and impact on functional impairment of excessive sleepiness and associated symptoms in nationally representative sample of adults. So participants queried about their sleep using composite international diagnostic interview. So responded were questioned about feeling sleepy during the day and falling asleep in permissive situations. So what is the result? So out of 5,692 people, 6% have said they have got difficulty awakening only. Another 6% said they insufficient sleep. There were 9% says both. There were 21% says falling asleep on the daytime, and all three were seen in 14%, 6%. Further, the study says excessive daytime plus associated symptoms were more common in female. The prevalence of excessive daytime plus associated symptoms were lower in adults with higher family income. Further, they have observed excessive daytime plus associated symptoms were less common among those who were working, students, homemakers, or retired. The prevalence of excessive daytime plus associated symptoms was not significantly different across different ethnic groups. Interesting. Survey done in US. In the 2000 Sleep Foundation Gallup survey conducted in United States, they have found out 20% of respondents reported that daytime sleepiness interfered with their daily activities. 8% fell asleep at work and 19% made errors at work because of sleepiness. Yet 61% of the respondents reported their primary physician had never asked how well they slept. With that, we'll go to the first case scenario. Mr. D, 61-year-old, retired chief engineer, previously diagnosed with type 2 diabetes mellitus and hypertension, presented with breathlessness for last 1 year. 1 year back, he developed shortness of breathing on mild exertion, which he didn't pay much attention. Over the year, shortness of breathing gradually increased up to MMRC grade 3. Additionally, he complained daytime sleepiness and snoring at night. No morning headache or episodes of observed apnea. He had daytime fatigability and experienced 3 episodes of near accidents while driving on the highway. Following this, he never drove. He had nocturia, which means he was waking about 6 times at night. Although his blood pressure was in optimal control previously, fluctuations were noted within the last year, needing frequent drug regime alterations. So he has, owing to his symptom, he underwent 2D echo and was found to have moderate to severe pulmonary hypertension. At that time, his Epworth score was 20, stop bank 4, BMI 30. Early morning ABG revealed high bicarbonate, 39 millimeter of mercury. Lung function study revealed obstructive airway disease. HRCT was reported as normal and started him on inhaler treatment, and sleep study was performed. It showed that HI of 19.8, but overnight sleep studies showed severe hypoxia in the night. His 32% of his sleep is less than 89 of the saturation. This is his trace. So he was diagnosed as obesity, hypoventilation syndrome and COPD overlap leading to pulmonary hypertension. After started on home BiPAP treatment, reassessment after few months was showed his breathlessness reduced up to MMRC grade 1 and he can walk 1 kilometer without stopping. Only one time wake up now, he is only one time wake up at night, no daytime sleepiness or fatigue, blood pressure is well controlled, weight reduced 12 kilos, now Epworth scale is 2. Repeat study, his average HI was 4.3 and latest echo shows previously noted pulmonary hypertension is not seen anymore. The second case, I conclude with this. 54-year-old mother of 3 children, works as a project officer in education office, diagnosed with hypothyroidism on thyroxine for 2 years, presented with gradually worsening daytime sleepiness for last 1 year duration. She was a loud snorer. During last few months, it was noticeably worsening. She goes to sleep routinely at 9:30 p.m. and sleep for 7 hours. She has a good sleep hygiene. She never went to deep sleep during her sleep. She was fully awake throughout her sleep. She even could recall what's happened in her surrounding next day. During her sleep, she experienced frequent interruptions, 6 to 7 attacks per night. She had choking episodes once or twice per month. Vivid dreams are very common. As a result, she awake with a headache. She doesn't have sleep latency. Feeling tired whole day, unable to concentrate. Preferred to be on the bed whole day, but gets angry with herself as she was not having any way to relieve her suffering. She was gradually trying to miss her routine work, neither enjoyed her work. So others have noticed that she was lethargic and irritable. Wake up once for urination. Some memory loss was obvious. She accepted that she has gained more than 10 kilograms over the last 1 year. History taken from husband. He also accepted that he is disrupted by the wife's loud snoring. Same time, all the family is suffering with the illness. So examination findings, BMI of 30, myelopathy score 4, Epworth score is 15, neck circumference 37, stop bank 2, ECG full T inversions were there, echo was normal, mild inferior basal hypokinesia. This is a sleep study. So HI was 53.5, of ODI 57.6. With that, this is a trace. So I am.
මට එහෙම නෙමෙයි මට මුළු දවසම හොඳට ඉඳලා නිදාගෙන නැගිටිනකොටයි මට ඒ මහන්සිය තියෙන්නේ. ඒ අමාරුව තියෙන්නේ. අර ලොකු වැඩ කොටසක් කරා වගේ තමයි මට මේ ඉඳගෙනකොට උදේ පාන්දර. ඉතින් මම ගෙදර හතර නැගිටින්න මත් කියන්න අත්‍යවශ්‍ය වැඩ ටික තමයි කරලා මුගේ වැඩ ටිකයි ගෙදර වෙන ටිකයි තමයි ඉතිහාමක් මට බැහැ කරන්නේ. ඒක කම්මැලි මෙහෙසයි කල කිරීමයි මොනවත් එක්ක මහන්සිය පුට්ටක් මොනවා හරි වෙනකොට උදේ නැගිටිනකොට ඉස්සෙල්ලා I'm not that සමහරවිට ඉස්සෙල්ලා. ඉතින් මම ડોක්ටර්ස්ලට ඇත්තටම කිව්වා ගිහිල්ලා. ඒ අපහසුතාවය මම මහත්තයාට දෙන්න කිව්වේ නෝ ඉතින් මේ වගේම කිව්වා. ඉතින් අවුරුනේ නැහැ වුණ ගානකට. ඊට මට එන්න වෙහෙසක් දෙන කිව්වා මම අපි ප්‍රශ්නේ නැගිට හැමදේට මොනවා යුද්ධෙක හිටියත් රැට අපි ඉඳාගෙන උදේ නැගෙන උඩ අර මහන්සිය ගිහින්නේ අපි නැකට මට එහෙම නෙමෙයි මට මුළු දවසම හොඳට ඉඳලා නිදාගෙන නැගිටිනකොටයි මට ඒ මහන්සිය තියෙන්නේ.
So with that, she had treated with sleep CPAP machine and she responded very well, and she perceived that now she's back to her baseline. So I will conclude my lecture. In the modern world, excessive daytime sleepiness is significant burden to the person, family and society. Early identification and treatment is critical for healthy living. Evaluation with good history and arranging a diagnosis workup will direct towards the optimum treatment. Need awareness among medical personnel, policymakers and researchers. Establishing a screening pathway in high-risk group and critical job holder might be the future of this endeavor. So, special thanks I would like to give to all the staff in Respiratory Clinic Galle for helping and conducting the sleep clinic even with the COVID era. Thank you everybody.
Thank you very much, Dr. Samanmali, for your nice presentation. I want to introduce the next speaker, Dr. Dilesha Vadasinghe, who is a consultant respiratory physician and a lecturer in physiology at Faculty of Medicine, University of California. Dilesha trained in respiratory medicine at National Hospital for Respiratory Diseases, Valisara, followed by overseas training in Royal Brompton and Harefield NHS Foundation Trust, where she exposed to sleep medicine and also domiciliary NIV, followed by further training there with transplant medicine and also host defenses at Oxford University. Over to you, Dilesha.
Thank you very much, Dr. Pool, for that very kind words of introduction. And I'd like to thank the college and the Sleep Assembly for giving me this opportunity today to speak. So this is not a very comprehensive lecture or talk on the full range of diagnostic workup, but this is just a stimulant to stimulate you to have an interest about this diagnostic workup of sleep-related breathing disorders and to read more, right? Okay, so I will introduce you to the investigations of sleep for sleep apnea, and I will highlight some normal aspects of sleep which you can't forget to interpret abnormalities in sleep, and then I will talk you through how to interpret a sleep study briefly. So this is to recap what the previous speaker have said, and we know that now sleep apnea causes sleep fragmentation leading to excessive daytime sleepiness, and also the hypoxia and the hypercapnia would trigger stress hormone release and lead to various cardiovascular complications, and both of them would lead to increased morbidity and mortality in these patients. So this very briefly, according to the International Classification of Sleep Disorders, the sleep-related breathing disorders are classified into 4 main groups. What are they? The central sleep apnea syndrome, obstructive sleep apnea syndrome disorders, and the sleep-related hypoventilation disorders, and the sleep-related hypoxemia disorders. So as Dr. Samanmali said very correctly, a comprehensive sleep history and physical examination is the cornerstone of the initial evaluation of any patient with symptoms of sleep-related breathing disorders. But keep in mind that clinical history and examination alone is not sufficient to diagnose sleep-related breathing disorders. So we need to do further investigations. And what are the investigations? You can do them for the diagnosis of the disease and also to assess for the risk, assess the risk and evaluate other comorbidities. So what are the investigations for diagnosis of sleep-related breathing disorders? Are the sleep studies. They're usually of basically 2 types: the attended polysomnography, which is done in a sleep laboratory, mainly in the hospital set up in Sri Lanka, and then the unattended diagnostic sleep studies, which are basically, we call them as the home sleep studies, right? And then a daytime blood gas, arterial blood gas, is very important in these patients, especially in the patients who are quite obese. And nowadays we can do transcutaneous carbon dioxide monitoring, which is fairly new investigation in Sri Lanka, and it's available only in very few centers over the country, such as I think Kandy was the first place to buy the monitor, and then Hambantota, and as well as the sleep laboratory, which is the small sleep laboratory, which I have just started at the faculty. Also, we have the facility to perform transcutaneous carbon dioxide monitoring tests. So, what is a sleep study? So, a sleep study, or we call it a polysomnography, is a comprehensive test which we can use to diagnose sleep disorders. This would record your brain waves, those are the EEG signals, your oxygen level in your blood, your heart rate, and your breathing. As well as in the full polysomnography, you can monitor your leg movements and eye movements as well. So, once these data are recorded or collected, these signals needs to be processed in order to be viewed. So, on to your left, you can see a sleep study recording system, which is a very old one, and it's an analog device. So, in order to view, you need to take printouts of many roll reams of paper to analyze. But now towards the left, you can towards the right of you can see the current digital recording systems, which are digital, and it is easy to adjust and for you to optimize and for you to read and view the parameters measured during the sleep studies. So basically, there are 4 types of or 4 levels of sleep studies which we can perform, out of which the type 1 or the level 1 sleep study is the attended laboratory-based polysomnography, and it would measure a minimum of 7 channels, including EEG, EOG, the chin EMG, ECG, heart rate, airflow, your respiratory effort, and your oxygen saturation. Also, snoring is included in this. And then the level 2 study or the type 2 study measures all 7, but it does not have a attended sleep physician in the laboratory at that time. So you can do it as a home sleep study, or maybe in ward where there is no sleep technician as well. Then the modifiable or the level 3 sleep study, we all know that Apnea Link is one of the home sleep study devices which is widely used in Sri Lanka in many respiratory centers, and it is a level 3 sleep study where you measure about a minimum of 4 channels during the sleep. And then if there is another level of sleep study, which is the level 4, where you measure either 1 or 2. Usually, the overnight pulse oximetry is a level 4 study, which we can use our transcutaneous carbon dioxide monitor to do a level 4 study actually. Right. So, as I said before, the attended polysomnography, which is the we can say the gold standard or the most appropriate study to diagnose sleep-related breathing disorders. So, would measure these 7 parameters: the EEG, electrocardiogram, chin and leg electromyography, airflow, your oxygen, arterial oxygen saturation, respiratory effort, ECG, and the heart rate together with snoring. And then these 3 parameters, the EEG signals, EMG signals, and your EOG signals are very important in identifying what sleep stage you are in. Whether you fall asleep easily, whether you do not fall asleep, when do you get your REM sleep, and all of those can be monitored using these 3 parameters. And I would not try to pronounce the second word, the surname of this well-known researcher, but Dr. Allen in 1968 has developed the first standard scoring system for human sleep stages together with Dr. Anthony Cales. And this was used for many decades until the American Association of Sleep Medicine took over and brought forward their manual for sleep scoring in 2007. So currently we use the AASM scoring rules for sleep scoring, which is the 2.6 version, which is unfortunately not freely available online unless you are a member of it or you purchase it. You have no access to this sleep scoring manual. So I will not go in detail to all sleep stages, but know that there are 4 sleep stages, the N1, N2, N3, which are the non-REM sleep, and the REM sleep, and W is the wakefulness. Each of these sleep stages have their own characteristics, EEG characteristics, which would give you a chance of identifying them separately, and which a sleep technician or the sleep physiologist will do the sleep scoring for you. Right, then the respiratory parameters. As respiratory physicians, the respiratory events are of more interest to us, and we use these signals to classify or identify the different respiratory disorders during sleep. So we use the airflow, respiratory effort, oxygen saturation, and the snoring sound. So basically, there are 2 major types of respiratory events, which are the apneas and the hypopnea. Apnea, as the word explains, self-explains, is cessation of breathing, and hypopnea is a reduction in the breathing flow. So apnea is defined as cessation of airflow for a minimum of 10 seconds during sleep, and based on the respiratory effort the patient or the subject would have, it's further divided into 3 types, which are the obstructive, central, or mixed type of apneas. But hypopneas, from the ASM recent developments or the guidelines, they classify it as just obstructive events only. So this slide would show you the different types of apneas. Here in central sleep apnea, the cessation of respiratory drive results in lack of respiratory movement. So there is no respiratory movement as well. There is no airflow. You will see a desaturation in them. In obstructive apneas, what happens is no airflow or 90% reduction in the airflow when measured, with continuous respiratory efforts, right? So that is the difference in obstructive and central. And in mixed, what happens is you see both parts. So there is no flow, and initially there will be no effort, but then towards the latter part you would see some effort. So this is another slide which shows the mixed apneas. So ideally or usually we would look for at least 3 or more obstructed inspiratory efforts during the latter part of a mixed apnea. Right. So the rules for this slide just summarizes the rules for the rules for scoring a hypopnea. So the peak signal of your flow should drop by at least or more than 30%, and the duration of the drop should be at least for 10 seconds, and there should be a desaturation of equals to or more than 3%, or the event should be associated with an arousal. So this is the latest hypopnea classification. So this in other terms, you would say that a hypopnea is an event when it's an event which is detected when a 10-second cessation or a reduction in signal drop, which we see about 70% drop in your respiratory flow signals, right? Okay, and then there is another term, the upper airway resistance, which we talk a lot about. In here, you would see, as you can see here, I'm sorry that this is a very small print and it's not very visible at the back, but then you would see a flattening of the pressure flow associated with snoring, and this is called the upper airway resistance. And then there is another kind of respiratory breathing pattern, which we call the Chine-Stokes respirations. And here, what happens is you would see a crescendo, decrescendo pattern of airflow. And the ASM has laid down another set of rules to diagnose Cheyne-Stokes respiration as well. I will not go into detail about it, but then you can see that there is a crescendo, decrescendo airflow pattern in Cheyne-Stokes respiration. So this would be much clearly visible. You can see a very nice crescendo, decrescendo pattern. Okay, now we know that there are many types of sleep studies, and I have introduced you to some of the very common terms we use when we are reading a sleep study. So I told you there are two types of sleep studies, the attended polysomnography or the home sleep apnea tests. So what do we offer to our patient? So usually all patients with signs and symptoms, what Dr. Samanmali told about indicating that they have increased risk of sleep apnea, should undergo a sleep study. And to decide whether it's a home sleep study, what kind of sleep study, we should look at other comorbidities. So if your patient has a significant cardiopulmonary disease, a potential respiratory muscle weakness or neuromuscular disorder, they have hypoventilation while they are awake or are at risk of sleep-related hypoventilation, they have stroke, opioid use, in severe insomnia, and symptoms of other respiratory, sleep disorders such as the limb movement disorders, and the environment for a sleep study, home sleep study is not appropriate, such patients should undergo a laboratory sleep study. All others can undergo a home sleep study as their initial investigation because it's less expensive as well as easy to be done because usually we can do it at their homes. Now, when we are talking about interpreting a sleep report, usually most of us are used to look at the AHI, classify whether they have a sleep apnea or not, and tell whether it's mild, moderate or severe, and then that's it. But that is not what we should be doing as respiratory physicians when you get a sleep report. So first you will have to see whether the patient has had a adequate length of a study. So for a home sleep study, ideally it should be at least 4 hours of recordings. And for a laboratory polysomnography, they have not specify the time, but then at least 2 hours of good quality sleep is what the some of the ASM documents mention. Right? And then you will have to also before looking at the numbers, go look at the graphical representation. There is a hypnogram and all the graphical representation of various sleep related breathing disorders. So look at it as well, and then look at your AHI. Also, just not the number, see what is during various body positions which your machine would record, what is the supine AHI, what is the non-supine OHI. Then you can identify the appropriate treatment for your patient as well. And then the oxygen values, the oxygen parameters are very important. So usually if the patient's saturation is less than 89%, the patient would need oxygen at night. But it is not universal for everybody. You can try CPAP. If the CPAP doesn't correct it, only you can think about whether you need to add a bit of supplemental oxygen at night. And then the ECG recordings, because with this hypoxia, it can trigger arrhythmias during sleep. So look at your ECG recordings as well. And also then the various limb movement recordings when you are using your sleep report. So the graphic summary, you will see something like this with various other panels, some of the reports what Dr. Samanmali showed as well. So this is a full night full polysomnography where you see the hypnogram as well. Sleep stages are recorded. So in order to interpret a sleep study, you should know that these in green, the REM sleep studies, REM sleep periods, you should have at least about 3 to 5 REM sleep periods during a good sleep, right? And Then there are various other things you can identify from the hypnogram, which I will show in my next slide. And the desaturation levels, you can get an idea about it, and the body position, whether the patient was on the right side, whether they were on the left side, whether they were supine, and all the details are in your sleep report. So this hypnogram shows, so from the time you're awake, when you go to stage N1, that's when you're start to sleep, so that is called the sleep onset, and then that period is called the sleep latency. And REM onset is when you start to have your REM sleep, and that part from the sleep onset to the time when you have REM, we call it REM latency, and then there should be at least 3 to 5 REM sleep periods during a sleep study. And these are just for reference. The sleep efficiency, which you'd see in numbers in your report, should be more than 85 to be normal. When you're aging, it would go down, and about 80% sleep efficiency is normal for an elderly person. Okay, so these are just numbers to remember. You don't want to remember, actually, you can just keep it with you and assess your sleep report so that you would know whether there is sleep fragmentation or whether the sleep architecture is altered using these numbers as well. So this is how your sleep report would show in numbers. Various sleep studies, various machines would give different reports. So the total recording time is seen, sleep period, the total sleep time, sleep efficiency is given, which is 87% in this patient, it's normal. And then the sleep latency and whether there are how many awakenings, how many REM periods, what is the REM latency. So there's a lot of information in your sleep report. Okay, so the interesting part, the apnea hypopnea index. So it is the number of all obstructive, central, mixed apneas and hypopneas you have during your sleep time per hour. Is called your AHI or the apnea hypopnea index. If it is 0 to 5, we tell it is normal and that they don't have sleep apnea. 5 to 15, it's mild sleep apnea. 15 to 30, we classify it as moderate sleep apnea. And more than 30 is severe sleep apnea. So remember, as I told, look at the body position, see whether your patient needs CPAP or can positional therapy improve his symptoms alone. Right, so this is because we are running out of time actually. So we will just briefly look at a sleep report. I'm sorry that I didn't have the graphic representation of this sleep report. The patient slept adequately. Now we'll start with AHI. AHI is 8.8 per hour, and this is mild sleep apnea. And you can see that the most of these events are hypopneic events, and only a little bit is apneic events. So in this patient with mild sleep apnea, because it's more hypopneas, not apneas, so it is not severe as having more apneas than hypopneas. So your sleep study can give you a rough idea about how early this patient should be on a CPAP machine, or intervention needs to be done. So when you look at the minimum oxygen level, the saturation is 82%. So he has significant desaturation at night despite not a low AHI. And then also when you look at the body position, you can see that during supine, his AHI is 18.3. While when he is non-supine, it's 4.9. So 4.9 is normal and 18.3 is moderate in this patient when he is supine. So positional therapy is also something what this patient can try. So in summary, this patient would have mild sleep apnea, which is mainly during the supine position. Okay, so finally a very few words about obesity hypoventilation syndrome. We know that it's defined as BMI more than 30. There should be daytime hypercapnia. They can have various types of sleep disordered breathing associated with the obesity hyperventilation, but make sure that you rule out all other causes of hypoventilation before you label this as obesity hypoventilation syndrome. Right? So there are about, studies have shown that 70 to 90% of patients with OH, obesity hypoventilation, has sleep apnea, and about 10 to 15% with sleep apnea referred to the sleep laboratory do have diurnal hypercapnia. So do a blood gas in your patient if you suspect obesity hypoventilation. Right. So in summary, sleep studies are key in diagnosing sleep-related breathing disorders. Do not only rely on the AHI alone when you are interpreting a sleep study. And the level 1 polysomnography is the standard test, but home sleep apnea tests are also helpful in diagnosing sleep apnea at the appropriate settings. Okay, right. Thank you. I hope that I was able to stimulate the interest in going home and reading more about sleep studies. Thank you.
Thank you, Dilesha, for that excellent lecture. Our next speaker is Dr. Damit Rodrigo, consultant respiratory physician, DGH Hambantota. He was trained in respiratory medicine at NHRD Valisara, and also he trained on sleep and domiciliary NIV at Royal Brompton and Harefield NHS Trust. Over to you, Damit.
Right. Thank you very much, Dr. Vatsala, for that introduction, and thank you very much for inviting me to deliver this lecture in this distinguished forum. Right. Okay. My topic is to discuss on the management of sleep-related breathing disorders. So far, we had two very interesting lectures on sleep OSA, symptomatology, and diagnostics by Dr. Dilesha and Dr. Samanmali. So we'll move on to my lecture now. So I thought of getting a case-based approach in this lecture. So my talk will be based on 3 case scenarios that I'm going to present to you now. So this first case is a 52-year-old man in the IT industry with a BMI of 32, has gastroesophageal reflux and premature right knee osteoarthritis, presents to you because his Apple Watch says that he stops breathing 20 times an hour during his sleep. So he's into this IT business, of an high-tech guy using this Apple Watch, and the Apple Watch now says that his breathing stops 20 times during his sleep. His wife says he occasionally snores during his sleep, but he reports a good quality sleep without any daytime somnolence. So he's asymptomatic in that case. He has a family history of premature coronary artery disease in his father, and therefore the patient is worried. Move on to the second case. A 42-year-old male banker with type 2 diabetes, hypertension, has a BMI of 28, presents to you because with symptoms of loud snoring, excessive daytime somnolence. His wife has noticed that his breathing literally stops at some occasions during his sleep, and he wakes up gasping on air for a few occasions. So it's a case of full-blown symptoms of OSA. He has recently rented a car driving home from work as well. Third case, a 55-year-old woman, a housewife with a BMI of 32 with refractory hypertension. That is, blood pressure was controlled on 5 antihypertensive medication. Had a recent primary coronary intervention to her right coronary artery after a positive exercise ECG. Referred from your cardiologist with the sleep study report, which indicates an AHI of 13 power. So cardiologist has gone ahead with the sleep study because he has felt that there's a risk for OSA. Again, this lady also has good quality sleep without any daytime somnolence. So she is also asymptomatic. So we have 3 cases. I have presented you 3 cases. So which case you would choose to investigate further, or you would rather choose to go for treatment is the key question now. Right. With that, we'll move on to my talk. So this is not the classic ICD-10 classification or something like that. I mean, in sleep disorders. Today, we are basically dealing with sleep-related breathing disorders, under which umbrella you get the obstructive sleep apneas, the central sleep apnea, nocturnal hypoventilations, and overlap syndromes. So I'll be basically touching on the obstructive sleep apnea and nocturnal hypoventilation management. Right. So objectives of my talk. first would be to discuss the management options for sleep-related breathing disorders, then to select the right or the correct patient for management or treatment, in other words, who should get treated in sleep apnea, discuss the different modes of positive airway pressure treatment or PAP treatment, that is fixed pressure CPAP, auto-titrating CPAP or APAP, and the BPAP or the bilevel positive airway pressure. Identify or to have a look at the novel or these non-CPAP therapies for OSA. There are some upcoming evidence, and to have a look at the current SRBD management guidelines, the different guidelines issued by different bodies, namely the American Academy for Sleep Medicine, the American guideline, the UK guideline jointly issued by the BTS, NICE, and the RCP, and the ERS. Right. So the first would be to discuss the management options. So as we all aware, these management options are basically divided into behavioral or lifestyle interventions, the gold standard positive airway pressure or PAP treatment, and non-CPAP therapies also. Right, so the behavioral or lifestyle interventions mainly focus on weight reduction and cutting down of alcohol, especially in the evenings, complete cessation of smoking, and avoiding of sedatives or sleeping tablets. So it's very important that these lifestyle interventions are started along with the more proven effective therapies like CPAP at the same time. Continuous positive airway pressure or CPAP is the treatment of choice for symptomatic moderate to severe obstructive sleep apnea, and it is the most effective way of treating symptomatic OSA. So what CPAP does is, or it functions as a pneumatic splint to maintain the upper airway patency by providing a pressure throughout all phases of sleep by preventing the airway getting collapsed. Right. So how would you select the correct patient for treatment, or else who should get treated in sleep apnea? Right. So here I would like to post you for options. How to select the correct patient. For you to select which group you should rather go and investigate further or treat. Should we be treating all those with OSA, obstructive sleep apnea, who comes to us and asks for treatment? Or should we be treating all those with OSA who are at a higher cardiovascular risk, regardless of their symptoms? Or should we be treating all those with OSA and symptoms? This is obstructive sleep apnea syndrome. Or should we be treating everyone, or should we be basically screening everybody for OSA and treat and diagnose and treat? So what I can tell you right now is this is what we are doing at the moment. We are investigating, we are in fact treating all those who are coming and asking, who are coming to us for treatment. This is what we are doing at the moment. Right. So how about screening everybody? I mean, should we be screening everyone for OSA? Should we pick everyone on the street and screen for OSA and do a sleep study and diagnose and treat? Is this effective, or is this cost effective? So the answer came from the US or United States Preventive Services Task Force statement, which was released in 2017. They looked at the evidence and they found that there were no studies identified evaluating the impact of screening and treating asymptomatic patients. So they concluded saying that the evidence is insufficient to assess the balance of benefits and harms of screening for OSA in asymptomatic adults. So if you, there's no point. Take everyone and screen them and diagnose OSA and treating. It's not effective actually. So So therefore. Treating, or investigating all with sleep testing or treating everyone with OSA is in fact not the correct way. So how about treating all with, these patients with obstructive sleep apnea with a high cardiovascular risk regardless of symptoms? So CPAP and incident cardiovascular disease risk, there have been a lot of research done on this area. This is one of the early researches done in 2005, published in the Lancet. This was an observational study where these researchers they studied a cohort of symptomatic obstructive sleep apnea patients. Mind you, these patients were symptomatic or sleepy patients. They had two groups. One group was willing to go for CPAP. The other group was not willing to go for CPAP, and they were given usual care other than CPAP. They followed up this cohort of patients for nearly 14 years and found out that the group of patients who were not willing to go for CPAP had a 2.9 times, or rather 3 times higher risk of higher risk of fatal cardiovascular event or not fatal or non-fatal cardiovascular events. So the conclusion was that in men, because this study was done only in men, severe obstructive sleep apnea or hypopnea significantly increases the risk of fatal and non-fatal cardiovascular events, and CPAP treatment reduces the risk. So this is with that people were doing a lot of randomized control trials. So this is the SAVE trial, the largest randomized control trial done to date with 2,700 patients. Mind you, they were non-sleepy patients, so this is very important because in randomized control trials you can't subject symptomatic patients, so they have taken non-sleepy OSA patients. And the study design was the study population, some were assigned to CPAP, a group of patients were assigned to CPAP, and the other group was given usual care other than CPAP, and they followed up this cohort of patients for 3.7 years. And you can for the presence of cardiovascular events. So you can see the two curves nearly overlap, showing that CPAP or continuous positive airway pressure had no significant benefit on reducing cardiovascular events. So the SAVE trial was a negative study. Then very recently, a couple of years back, this famous ISAC study was also published. Again, quite a similar study design. They got actually patients who had a recent acute coronary event, and again, patients, a cohort of patients with obstructive sleep apnea who were again not symptomatic. This is again a randomized control trial, and followed up these patients for nearly 72 months, and again found out that CPAP doesn't reduce the cardiovascular events. And again, this was a negative study. So they conclude saying that among non-sleepy patients with acute coronary syndrome, the presence of OSA was not associated with an increased prevalence of cardiovascular events, and treatment with CPAP did not significantly reduce this prevalence. Right. Here in this slide, I have shown the complete meta-analysis of all the randomized and non-randomized control trials done on this area, CPAP and cardiovascular events. When you categorize them into randomized and non-randomized control trials, these studies, you can clearly see a difference. In randomized control trials, you tend to see, almost all of them have resulted in a negative study. There was CPAP was not showing any significant benefit. But when you focus on the non-randomized control trials or the observational studies, they have resulted positive. So why is the difference? It's quite simple. It is the methodology of these studies, because as I've told you before, in randomized control trials were basically done on patients who were non-sleepy or who were not having symptoms, because you can't subject sleepy patients, you can't deprive them of CPAP, and therefore they have not shown any benefit. But in non-randomized control trials, they have taken sleepy patients, and therefore they have clearly shown benefit from CPAP. So this itself shows that it is the symptomatic patients or the sleepy patients that would benefit from CPAP. Right. So treating all with OSA because they have a high cardiovascular risk regardless of symptoms is again should not be the way forward. So it is the group that we should rather focus on is a group with obstructive sleep apnea and symptoms. In other words, obstructive sleep apnea syndrome. Right. But still, having said that, there's an exception. This is the refractory hypertension group. This study, which consists of 194 patients with elevated blood pressure, basically patients with resistant hypertension, that is hypertension, the blood pressure was controlled on 3 or 4 antihypertensive meds, or refractory hypertension, whose blood pressure was controlled on more than 5 antihypertensive medication with moderate to severe obstructive sleep apnea, were I mean, again, they had two groups. One group had CPAP and the other group had usual care other than CPAP, and they followed up these patients for 12 weeks for their blood pressure. And you can clearly see the refractory group, refractory hypertension group, they had significant reduction in their blood pressure with CPAP. So CPAP has a benefit, has a place in reducing the blood pressure in the refractory hypertension group. So back to my case scenarios. The first case, this patient, this asymptomatic man who came to you because his Apple Watch says that his breathing stops in the night. He had no symptoms to improve, and there's no evidence that cardiovascular disease risk will improve with treatment. Therefore, all what he needs is counseling on evidence-based weight loss interventions. My second case, the male banker with symptoms, full-blown symptoms of OSA, he needs further testing for OSA and initiation of CPAP along with lifestyle interventions. The third patient, the asymptomatic obese woman with refractory hypertension who recently had a PCI, she needs CPAP. She will benefit from CPAP, though she was asymptomatic. She had she had resistant hypertension, and CPAP has a place in reducing her blood pressure. Right. So I'll pick my second case and move forward. This 42-year-old banker who had these comorbidities. He was symptomatic with the Epworth Sleepiness Scale score of 18. Wife has noticed witness apneas. He has had a road traffic accident as well. We have gone ahead with the sleep study, and the apnea hypopnea index is 55 now, which showed severe obstructive sleep apnea. Right. So how would you manage him? Yes, of course, he needs initiation of CPAP after proper counseling with lifestyle interventions, focusing on weight reduction. Right, so with that, we move on to my third part of my talk to discuss the different modes of PAP treatment. Right, so this is the traditional obstructive sleep apnea care delivery model. Once you have a patient with possible obstructive sleep apnea, you do a in-lab sleep study, as Dilesh told, or a home sleep study, of course, and then you have to do a CPAP pressure titration to find out the ideal pressure that you should set in a fixed pressure CPAP machine to this patient. And once you find that out, you set that pressure on a fixed pressure CPAP and you initiate CPAP and then follow up this patient. So this is the traditional OSA care delivery model. So having said that, we have two important modes, the CPAP mode and the APAP mode. So in CPAP, what we do is we set a fixed pressure after finding that pressure from a pressure titration, and we set the pressure manually on a fixed pressure device, and that is the pressure that the patient will get throughout his sleep. And then we have this APAP, or the auto-titrating CPAP mode, where these machines are more sophisticated because they can sense the patient's airway resistance and can deliver a different pressure, because you are setting a pressure range, say from 5 centimeters to 20 centimeters of water like, and the machine senses and delivers a different pressure depending on the patient's resistance. This is what we call the APAP, or auto-titrating PAP. So once you screen and diagnose, then you have to do a pressure titration that you can do manually. There's two ways of doing a pressure titration: a manual titration with in-lab polysomnography, a sleep technician sitting with the patient while the patient is sleeping, and according to the polysomnographic data, the technician manually titrates the pressure and find out the pressure, and then you start the patient on fixed pressure CPAP. This is the traditional pathway. Or else, once you diagnose, you can straight away start the patient on auto-titrating PAP or APAP by giving a range of pressures, and the patient, you can send the patient home. This is more convenient. Right, so APAP versus CPAP. So there have been a lot of researches done on this area. This is a meta-analysis comparing auto-titrating PAP versus continuous positive airway pressure. You can see that APAP, or auto-titrating PAP mode, was superior because it increases the patient's compliance or CPAP adherence and also reduces the patient's symptoms. So the preferred approach is auto-titrating PAP. You can set a pressure range. Usually the range that we start is we give is 5 to 20 centimeters of water. What about the nasal? What about the mask interface? As we know, we have basically three types of mask interfaces: the full face mask, the nasal mask, and the nasal pillows. So, how would you select which type would be the ideal for your patient? This is the largest clinical or the observational. It's an observational study done on this subject, done in France. They have found out that nasal interface has the highest. It is the best. I mean, in terms of patient's adherence, it was 2 times better than the full face mask, and therefore it is more preferred for the patients. So back to my second case. Now we have diagnosed this patient and started the patient on APAP or auto Cpap with a minimum pressure of 5 and a maximum pressure of 20. We have set a pressure range, and we review our patient at 3 months. Patient reports less snoring now, but he still has daytime somnolence. He still complains of waking up with headaches in the morning. So what could be the reason? Can this be a lack of compliance? Well, you can easily sort this out by having a look at the compliance data from the machine. It seems to be satisfactory. So then at this point, we decide to go for the pressure titration report. In the APAP or the auto titrating machine, the advantage is you can get the pressure titration report of the patient. This is the trace. You can you can get the previous night trace, like, so you can clearly see that the patient has needed very high pressures to counteract the apneas. His pressure, the pressure which was given by the machine was around 15 centimeters of water, which is a relatively higher pressure. So at this point, we suspected whether this patient has an element of hypoventilation or nocturnal hypoventilation. Therefore, we decided to go for a transcutaneous overnight carbon dioxide assessment study. This is what we call the TOSCA. So while the patient was sleeping with the CPAP machine, we have gone for a TOSCA study or transcutaneous carbon dioxide trace throughout the sleep to measure her overnight carbon dioxide tension. The lower graph shows the carbon dioxide trace. You can clearly see that, I don't know whether it's clear to you. So the carbon dioxide tension was well over 7 kilopascal, the transcutaneous carbon dioxide, which clearly indicates that this patient has nocturnal hypoventilation. Right, so the patient's overnight CO2 trace was over 7 kilopascal, indicating significant nocturnal hypoventilation, and therefore the patient was switched to the BPAP or the BiPAP mode with an EPAP of 10 and an IPAP of 20. So we have a pressure support of 10, and the patient symptomatically improved. So the learning point here is in severe obstructive sleep apnea may be associated with nocturnal hypoventilation, which may not be addressed by CPAP alone, and these patients' treatment has to be escalated from CPAP to BPAP or BiPAP. So the next, my next objective is to have a look at these non-CPAP therapies. I'm not going to discuss much about this because we have 3 eminent speakers who are going to talk about these non-CPAP therapies in a while. Mainly the gastric bypass surgery, this mandibular advancement spins or devices, this hypoglossal nerve stimulation. There's some new evidence coming up on this subject. Myofunctional therapies, these maxillomandibular osteotomies, and there's some new evidence coming up on carbonic anhydrase inhibitors as well. A couple of weeks back, the ERS issued a guideline on non-CPAP therapies of OSA. I suggest you go and have a look on that paper as well, because that actually gave a guideline on non-CPAP therapies, especially for those who are not willing to go for CPAP. Right. The last part of my talk would be to have a look at the guidelines and guidelines devised by different bodies. So we basically have the American guideline or the AASM, American Academy for Sleep Medicine guideline. So this is, I'm not sure whether it's clear. So This guideline basically shows that once you diagnose a patient with obstructive sleep apnea syndrome, and if you have to, you discuss the clinician discuss with the patient of the possible treatment options, and if the patient then willing to go for CPAP, you assess for comorbidities. If the patient has comorbidities, you do a pressure titration, have to do a pressure titration, and then go for fixed pressure CPAP mode. If the patient has not much comorbidities, you can straight away offer the patient APAP or auto-titrating PAP. This is the UK guideline jointly issued by the BTS, NICE and the RCP. Basically, this guideline they divide it is divided into three groups: mild OSA group without symptoms, and the guide what they say is they only need these lifestyle interventions, and mild OSA, mild to moderate. Mild OSA syndrome and moderate to severe OSA syndrome needs CPAP. The UK guideline has a separate guideline for obesity hypoventilation syndrome as well. And there's the third part is the COPD, obstructive sleep apnea, hypopnea syndrome overlap guideline, or the overlap syndrome guideline. So I think you can have a look at these guidelines in the internet. So this is the guideline that I've told you. This was released a couple of weeks back, the ERS guideline on non-CPAP therapies, which discuss some novel upcoming therapies or non-CPAP therapies for obstructive sleep apnea, especially for patients who are not willing to go for CPAP. So in summary, in obstructive sleep apnea, the group of patients who would most likely benefit from treatment or diagnosis and treatment are the group with symptoms. There is insufficient evidence for screening and treating asymptomatic patients. Still, there aren't enough evidence to support treating OSA with high cardiovascular risk, regardless of their symptoms. With regard to obstructive sleep apnea and cardiovascular risk, observational studies, non-randomized control trials, have assessed symptomatic patients, while randomized control trials have recruited non-sleepy patients. Hence, there's a difference between the RCTs and non-RCT evidence. Cpap initiation using APAP or auto-titrating PAP is preferred over the fixed pressure PAP, since the former increases the compliance. Out of the interfaces, nasal interface has the highest evidence for treatment adherence. Patients on CPAP not improving their symptoms should have their pressure titrations checked and subjected to overnight transcutaneous carbon dioxide monitoring to pick up nocturnal hypoventilations and switched over to the BiPAP or the BPAP mode. There is some upcoming evidence for non-CPAP therapy, especially for those who refuse PAP treatment. So that's it. Thank you very much. Thanks.
Thank you very much, Damit, for your comprehensive talk on management of sleep-related breathing disorders. Our next speaker is Dr. Kishar Gunaratnam. Can I have a slide? Dr. Kishar Gunaratnam is a board-certified neurologist with a special interest in epilepsy. He underwent overseas training at the National Hospital of Neurology and Neurosurgery, Queen's Square, London, and Oxford University. He works currently as a senior lecturer in medicine and an honorary consultant neurologist at the Department of Medicine and Mental Health, Faculty of Medicine, University of Maratua. Over to you, Dr. Kishar.
Thank you very much for that kind introduction, and I'd like to thank the Sleep Assembly in giving this opportunity to speak to you on neurological sleep disorders and overview. This is by no means a comprehensive lecture. It will touch upon a few of the neurological sleep disorders that and the common neurological disorders that one might encounter. So as you know, sleep-related disorders are a group of illnesses with marked effects on patients' quality of life and functional ability, as the previous speakers have highlighted to you before. Since sleep disorders often remain undiagnosed, the actual prevalence of sleep disorders is generally unknown, but certain studies suggest that the prevalence is between 10 and 15% of the general population, but that can, certain studies actually suggest even higher rates of nearly 30% or so. And this is mainly because sleep disorders still remain often undiagnosed. Right, you've seen this classification before. This is the International Classification of Sleep Disorders. And basically all sleep disorders are categorized into these 6 categories, which include insomnia, sleep-related breathing disorders, central disorders of hypersomnolence, circadian rhythm, sleep wake-up disorders, parasomnias, and sleep-related movement disorders, of which you've heard a lot about sleep-related breathing disorders. I'm obviously not going to touch upon that. We will be touching upon the other categories, which fall under the domain of neurology. So, symptoms of sleep disorders, generally, the 3 cardinal symptoms are either they have inability to fall asleep or sleep through the night. They can have excessive daytime sleepiness or daytime hypersomnolence, or they may have sleep-related movement phenomena. So often the patient will come with one or a combination of these cardinal symptoms. So my talk will be based on these cardinal symptoms. So lack of sleep, insomnia. So this is a disorder which involves, it's a disorder of initiation and or maintaining sleep. And this is generally referred to as insomnia. And it's generally classified into primary and secondary. Primary insomnia is where there is no organic cause that we can find. And generally in primary insomnia, women are most likely to be affected more than men. And it is often, it is also more prevalent in the elderly because of the physiological, most often, the physiological changes that one might see with the sleep cycle as we age. Problems with primary insomnia is that it can be a risk factor. There are more and more studies that support the possibility that these patients are at a higher risk for dementia, and also psychiatric comorbidities such as anxiety disorders as well as alcohol dependence. Secondary insomnias can be caused by several medical conditions, of which the commonest cause or number one cause for secondary insomnia is actually psychiatric comorbidities. Examples include depression, anxiety, alcohol dependence. Of course, disorders involving the central nervous system, like any form of neurodegenerative disorder or inflammatory or disorder, even tumors can cause secondary insomnia. Polyneuropathies, especially painful polyneuropathies or small fiber neuropathy, which causes a lot of pain, especially at night, can be a secondary cause for insomnia. RLS or Restless Leg Syndrome, quite common to cause insomnia. Sleep-related, so OSA as well, a cause for insomnia. Heart failure, endocrinopathies like thyrotoxicosis, and sometimes external factors such as loud noise, shift work, and so on and so forth. So these are the secondary causes for insomnia. Now we shift on to increased sleepiness or daytime hypersomnolence. So this is more of an algorithmic approach that one could have when assessing daytime hypersomnolence. So if a patient comes to you with daytime hypersomnolence, you start off by trying to gauge whether the patient's got a sufficient amount of sleep or not. And if it's no, it is more likely that the daytime hypersomnolence, like most of us, who it's as a result of sleep deprivation. And that again can be due to, again, insomnia per se, whether it be primary or secondary. If the patient's got enough or sufficient sleep, is the sleep refreshing or not? So if the sleep is sort of not refreshing, if the patient wakes up saying that he's more or less tired, if it is not refreshing, then you need to ask whether the patient's got sleep disturbance during the night. So if there is a disturbance in sleep, then if it's yes, and then the possibilities are that the patient may be having RLS, periodic limb movement disorder, and other causes that can disrupt sleep. If the patient's having refreshing sleep, then you need to assess whether if the possibility to, you need to ask the patient whether he is able to sleep at night, and if the answer is yes, then the most likely cause is central hypersomnolence, of which narcolepsy and idiopathic hypersomnia are causes. If no, then it's most likely that you're dealing with a circadian rhythm disorder such as shift work, advanced phase circadian disorder, or a delayed phase circadian disorder. So as you can see, an algorithmic approach to daytime somnolence might give you an idea as to what kind of disorder you are dealing with. Now, so I'm going to talk a little bit about narcolepsy, which is again an idiopathic cause for excessive sleepiness. So the cardinal features of narcolepsy include excessive daytime sleepiness, where there are uncontrolled episodes of falling asleep during the daytime, and these are called sleep attacks. And or prolonged sleep not explained by other disorders. There are two types. There's type 1 and there's type 2. Type 1 is narcolepsy with a phenomenon called cataplexy. I'll come to cataplexy in a little while. And type 2 is narcolepsy without cataplexy. So the other features are especially of type 1 narcolepsy is hypnagogic and hypnopompic, or hallucinations, or vivid hallucinations when you're about to fall asleep or when waking up. Sleep paralysis, so as soon as you wake up, the inability to move, which is very frightening. Automatic behaviors during this period of waking up and falling asleep might have behavioral changes which are attributed to falling asleep where the patient is unaware of, and of course fragmented sleep at night. So these are features that we would see with narcolepsy. So this is a video of cataplexy.
So here's a person actually with the history of narcolepsy, and this video is actually going to demonstrate this process of cataplexy that these patients frequently have. That's a circumstance where you just kind of like lose muscle tone, become even almost paralyzed.
So unfortunate.
Yeah. And so let's take a look at this. And oftentimes it's actually this video clip is someone who was demonstrating like a dance exercise, and because the person's background pathology just happens to capture this moment right on the videotape. So let's take a look at that. So here she is describing like these dance motions, and then we'll see just this abrupt like loss of motor tone, and because this person has underlying narcolepsy, we'll actually see like this person just goes out this profound deep sleep. So a terrible actually circumstance to
That's
have.
what cataplexy, just that sudden paralysis, and then all of a sudden you just have.
So as you can see in the video, it's a sudden loss of tone, often triggered by a strong emotional stimulus. Sometimes just laughing at a joke might actually trigger one of these events, and often these are misdiagnosed as non-epileptic events or syncope and so on and so forth. But as you can see, there was no loss of consciousness. But in the video, you did see the patient going into sleep very, very quickly, which is called a sleep attack, seen with narcolepsy. Of course, all patients with cataplexy don't look like this. Right. So there is type 1 and type 2. Type 1 is often associated with, there is an HLA association. There is this the proposed mechanism of narcolepsy as with the suggestion is that it is a autoimmune pathology or pathophysiology. Of course, there is no strong evidence to suggest that. There seems to be a disturbance of the hypercretin orexin system, which is required to maintain wakefulness in narcolepsy. And especially with type 1, where we observe cataplexy, the CSF hypercretin or orexin levels are very, very low. We don't see that too much with the type 2. And the diagnostic tests that we would generally do are MSLTs or multiple sleep latency tests, where we would have a threshold of less than 8 minutes to diagnose narcolepsy. Of course, with the combination of sleep onset REM. So that's a bit about narcolepsy. The other disorder that goes hand in hand with narcolepsy is idiopathic hypersomnolence. Again, excessive daytime sleepiness. Of course, without the REM-associated symptoms such as sleep paralysis or cataplexy. These are the diagnostic criteria. You can have daytime lapses into sleep, or it is irrepressible need to sleep on a daily basis. They would sleep for hours and hours and hours. Sort of even if they wake up, they're confused, they don't know what they're doing, which is called sleep drunkenness. They don't really even recall what they have done for a few hours sometimes. And there's an absolute requirement to sleep for hours and hours and hours. There's absence of insufficient sleep syndrome, absence of cataplexy, obviously, which with the presence that would suggest narcolepsy, absence of other causes of hypsomnia, which is, and often drugs can be a cause. And of course, the presence of a positive MSLT. They don't have, like in narcolepsy, sleep onset REM sleep. So we've spoken about lack of sleep, more sleep, and now movements in sleep. So of which parasomnias are the commonest type of sleep disorder that we would generally encounter. And it is a sleep disorder that involves unusual and undesirable physical events or experiences that disrupt sleep. Parasomnias can occur before or during sleep, or indeed during arousal from sleep as well. Generally categorized into REM sleep associated parasomnias and non-REM sleep associated parasomnias. They can often be mistaken for nocturnal seizures as well. So it is often a differential diagnosis that we need to consider, especially when because of the treatment options being completely different. And this is a slide that would generally try to differentiate the two, especially nocturnal frontal lobe epilepsy or seizures can mimic non-REM parasomnias and vice versa. if the events are multiple during the night, it's more likely that you're dealing with seizures. If it occurs during N2, it is more likely that you're dealing with a seizure, whereas we often observe non-REM parasomnias during N3. If it is very stereotypic, short-lasting, generally lasting less than 1 minute, you're most likely dealing with a seizure than a parasomnia. So those are the main cardinal features that you'd look for, especially on a PSG or a polysomnography when you are assessing for non-REM parasomnias. These are the examples for non-REM parasomnias and REM parasomnias. The highlighted ones are the commonest. Night terror, sleepwalking, or what we call somnambulance, is often seen in children, young children and young adults. And we do see the people experiencing these overflowing onto adulthood as well. So, of course, that being the minority. But these are the two most common parasomnias that we would generally see. Of course, we also see sleep-related eating disorders, and which may be a cause for obesity as well, and a known non-REM parasomnia. Confusional arousals, bruxism, enuresis, sleep staring, sleep talking, head banging, all examples of non-REM parasomnias. REM-related parasomnia, the quintessential or the stereotypical example is RBD or REM sleep behavior disorder. And of course, sleep paralysis, which is very, very frightening for patients who actually experience it. A little bit about REM sleep behavior disorder. RBD is characterized by movements during REM sleep. So when you actually assess the polysomnogram, the mental leads over the mentalis, during REM sleep, it's a flat line. There is no muscle activity. But if you do observe muscle activity during REM sleep, the most likely diagnosis is that you're dealing with a REM sleep behavior disorder. You can have very complex movements. They are often quite violent. And in most cases, these patients are actually acting out the vivid dreams that they would generally experience. And this might often result with injury either to the patient, him or herself, or the bed partner. So it's quite violent and can cause injury. And it may be a precursor to a neurodegenerative disorder. There is idiopathic REM sleep behavior disorder, and there's of course secondary causes for REM sleep behavior or RBD, of which Parkinson's or Parkinson disease is one of the main causes for RBD, which is alpha-synucleinopathy. Of course, the other being multisystem atrophy. So you might have RBD preceding these neurodegenerative disorders many years before the actual onset of the neurodegenerative disorder. A little bit of how RBD would look like. Sorry, you need to wait for a little while. You might fall asleep while. Even now you can, if you notice the red line, that's EMG activity, which is probably not expected during REM sleep, and you can see the movements now quite Um, All right, so this is quite an interesting phenomenon where you see fairly violent movements, especially during sleep, REM sleep, where we would expect complete atonia. All right, can be often also mistaken for a nocturnal seizure as well. Okay, a little bit about restless leg syndrome. These are the clinical criteria. It's generally an unpleasant sensation. You can have a little bit of paresthesia. You may have pain. You may have the sensation of like animals crawling up your legs. It's often associated with your legs. Typically occurring during periods of rest, and it's partially or totally relieved by movement, and it has a circadian rhythm where there is worsening towards the evening or at night or close towards bedtime, and can be very disabling and can cause sleep disturbance, and it is often associated with a periodic limb movement in sleep. So often they go hand in hand. Symptoms are often, and the diagnostic criteria also suggest that they're not explained by another condition. There are various associations with RLS. It's often, in the majority of cases, it's idiopathic. Can have a 10% chance of it being familial as well. Can be secondary to iron deficiency, so it's important for you to do a serum ferritin, and if the ferritin is low, you need to basically supplement those patients with iron therapy. Chronic kidney disease is again a common association. Heart disease, diabetes, Parkinson's disease, very common complication of Parkinson's disease, and Parkinson's disease has a variety of sleep disorders associated with this, of which RLS is an example. Drugs, again, antipsychotics, SSRIs, steroids, beta-adrenergic agonists also can trigger RLS. A little bit about periodic limb movements in sleep. It's generally characterized by repeated leg jerks or kicks during sleep, often associated with the lower limbs, but can be associated with the upper limbs as well. And generally you see these movements repetitively over the course of sleep. It is often seen in non-REM sleep. And generally we require generally a fixed number of movements to sort of diagnose it. A minimum of around 15 kicks or abrupt movements of the lower limbs is an requirement for the diagnosis. Just to show what it looks like, it's often associated, as I said to you before, with restless leg syndrome. So the brief flexing of the leg, if you observed those movements, and these would occur repetitively over non-REM sleep, and often causing fragmentation of sleep and frequent arousal. Sometimes the patient is aware. In most cases, the patient is unaware, and it's actually you need to basically inquire from the bed partner whether these movements are present or not, and that can cause daytime hypersomnolence. The last few slides, this is on circadian rhythm sleep disorders, and it's a group of disorders which are, so it's very simply put, it's desynchronized, or your body clock or your circadian rhythm within is not in sync with the day, the night-day cycle, which is an external factor. So it's not, it is not in sync, and that's what it means, right? These are the examples of circadian rhythm sleep disorders: delayed sleep phase, advanced sleep phase disorder, non-24-hour sleep-wake disorders, irregular sleep-wake rhythm disorders, jet lag, and shift-work sleep disorder. These are the examples that we would have, and just to make you understand what it means. So this is normal sleep, where one would sleep at a reasonable hour of between 8 and 12 a.m. and then wake up before 8 a.m. Fairly long sleeping hours, not so much the sleep that I would have, but half of us are sleep deprived anyway. Right, so so if it's advanced sleep phase, then it's where the patient or the said person would sleep far earlier and wake up far earlier. So that's what it means, advanced sleep phase. Often seen with the elderly. It's very common, where they sleep much earlier and wake up very, very early. And of course, then we see the delayed sleep phase, where they sleep much later and wake up much, much later. And often seen with adolescents, apparently, because they are partying all the time. Hope we can do that as well. Right. So the irregular sleep-wake rhythm is where there are these short naps right throughout the day, where there's frequent sleeping and awakening. So just often these are brought on by our own lifestyle, and even shift work is the same, where we should be sleeping when we should be awake, and people are awake when they should be sleeping. So these are the circadian rhythm disorders, and this comes to the end of my brief overview of neurological disorders. So in conclusion, sleep disorders in neurology are very heterogeneous, or heterogeneous. It's a heterogeneous group of disorders with diverse manifestations, as you can see. Their proper diagnosis can prevent secondary diseases, because there is quite a lot of secondary diseases that are associated with these disorders, and prevent the worsening of concomitant conditions. So I thank you for your attention.
Thank you, Dr. Kishar, for that informative and interesting lecture. Our next speaker is Professor Titration Wijeratne, who will be talking to us about outcomes of bariatric surgery in sleep-related breathing disorders. Professor Titration Wijeratne is a consultant surgeon and professor in surgery at the Department of Surgery, University of Sri Jayawardenepura, and he is a board-certified general surgeon with special interest in laparoscopic upper gastrointestinal and pancreatobiliary surgery. He has been trained in Australia in bariatric and metabolic surgery and has been in practicing the same for the last 11 years. Over to you, Professor Titration.
Thank you very much, Madam Chairman, and thank you very much for the President and the Council of the Respiratory Physicians for giving me this opportunity to be here. And of course, a word about Dr. Amita Fernando. I can't see him here. 12 years ago, when we started these operations with very obese patients, there only very few people were there to help us, especially in the respiratory field, because anesthetizing these people were a nightmare. And Amita Fernando did a marvelous job in actually initiating Cpap therapy and assessing these patients and making them safe for surgery. And he has trained a lot of young, enthusiastic respiratory physicians who work with us, and like Chandimani and so on and so forth. But it was that single-handed effort of Amita Fernando which has made all this possible for us to kind of cure most of these people who otherwise would have died with severe obesity hypoventilation syndrome. So with that, I would start talking about outcomes of bariatric surgery in sleep-related breathing disorders. And I'm not an expert in the respiratory cycle. I'm quite an amateur here, but I would tell you what I see as a surgeon in this particular field. Sleep-related breathing disorders are very common among obese. We have heard it over and over again by the several speakers who have already spoken. As Amita in his talk mentioned, the joy, the fat boy in the Pickwickian, the Pickwick book, Pickwick books in so-called in the Charles Dickens book. So out of I think from there we have started naming this syndrome as Pickwickian syndrome. So obesity hyperventilation syndrome, OHS, is the main disorder affecting the obese and also the sleep in obese patients. And it's a complex interaction between sleep distorted breathing, diminished respiratory drive, and obesity associated with respiratory dysfunction. So to diagnose obesity hyperventilation syndrome, in the classic scenario, your body mass index has to be more than 30, equal or more than 30, and awake hypercapnia of PaCO2 more than 45. Now, but there are several new definitions for this. I will not go into details of that, because there is this subgroup where they have the symptoms, but the arterial PaCO2 at daytime are not reaching 45. They are a kind of an intermediary group who will eventually end up in the OHS category. Of course, other causes of awake hyperventilation, such as lung or neuromuscular disorders, have to be excluded. What's the problem with OHS? Why are we worried about this? You see, the mortality is 23% within 1.5 years after diagnosis, if not treated effectively. So this disease is a killer. About 194 patients will roughly die within 1.5 years, that is 18 months of follow-up. There is a very important paper that has been published on this subject where they have followed up these patients as to what happens. So that's why this disease has to be addressed. How common is it? It will be seen in about 10 to 20% of patients presenting to respiratory or sleep clinics. I mean, you all will be seeing this in the range of about 1 in 6 to 1 in 5. Quite common in your clinic practice. And over 50% of the super obese, now that is BMI over 50, who get hospitalized, will have this syndrome. Then a lot of our speakers have been speaking on data from what has been happening abroad, but I'll be talking on data from Sri Lanka. So in Sri Lanka, the prevalence of obesity we know is about 14%, pretty high for a South Asian country. And analyzing our data over the past 12 years, the mean BMI of the patients undergoing bariatric surgery and my care was 44.7, that is about 45. So you can see, once again, for an Asian bariatric surgical practice, this is a pretty high figure. And you can imagine the number of obesity hyperventilation syndrome patients who would be among these people. Why does obese get it? What is the problem? What are the postulated mechanisms? There are obesity-related changes in the respiratory system. I will not go into details of that. There are alterations in the respiratory drive. That's a central problem. And there are breathing abnormalities during sleep, which are more commonly or exclusively seen in obese people, which are not seen in normal people. As you know, you all have been talking about the neck circumference or increased waist to hip ratio associated with the neck circumference. Increased neck circumference is due to excess fat deposition. And these compress the upper airway. This upper airway collapse, especially in the sleep, in supine position, is a big problem. And the ineffective ventilation, the excessive fat deposition around in the mediastinum as well as around the lungs, the chest wall itself produces ineffective ventilatory efforts. And the visceral fat, which in supine position pushes the diaphragm up, which makes the lower zonal ventilation a problem. And these people have their end respiratory expiratory volume is high, and there is carbon dioxide retention and alveolar air retention in the lung bases in these people. And Amita has also been speaking about leptin. Now, leptin levels, actually talking about in the obese, many studies show that the leptin levels are actually high in the obese. So if you apply the real leptin therapy, they should be eating less, but it doesn't happen that way. Because in the obese, there is this unknown mechanism where the central leptin sensitivity is absolutely very, very low. So this central leptin deficiency or the insensitivity is the thing which will keep on, although the leptin levels are high, leptin does not act on your hunger centers. So that is the problem in these people, so on and so forth. There are so many other hormones which act centrally in the obese to drive their obesity and to reduce the effect of or the effective breathing in the night. So what are the management options? We have all heard about PAP therapy. There is a component of non-invasive ventilation. And of course, some of these patients have underlying asthma and other sleep issues, other respiratory issues which need to be treated before we get on with the PAP therapy and so on and so forth. But the problem is in the obesity hyperventilation syndrome, the obesity is the underlying cause of the disease. So effective weight management therapy is essential, because without that, whatever the other treatments that are being done will long-term be ineffective. So it's been clearly proven today the bariatric surgery is the most effective treatment option in long-term management of obesity hyperventilation syndrome. And this, of course, there was a lot of fear, a big fear about getting these patients to operation beds, because everybody knew that this can be cured, or that this can be virtually treated very well by bariatric surgery. But the risk of an obesity hyperventilation syndrome patient undergoing bariatric surgery has been the key issue in physicians and patients getting these operations done. But we know today that the higher surgical risk in an obese patient with OHS in underlying surgery can be effectively treated in pre-op Cpap therapy. And this is what we have been doing over the past few years. And we have been, you guys, the respiratory physicians, have been doing a lot of work in making these people absolutely safe for our anesthetists to anesthetize and for us to go ahead safely with the surgery. And of course, we together see the beautiful outcomes of these operations later on. So a little bit about the management of obesity. This, you see, just like a lot of obesity related illnesses, OHS is also kind of affects the Asians much earlier or much severely than the Westerners. So because of that, the new Asia Pacific guidelines in management of obesity have reduced the interventional parameters in BMI. So some of you may not be aware of this, that's why I put up this slide. So traditionally we say overweight is BMI 25 to 29, in Asia Pacific is over 23. And there is this at-risk category, 23 to 25, that is Asia Pacific guideline. Class 1 obesity is 30 to 39, kind of 35 in the standard classification, but for us it's 25 to 30. So 35 to 40, we have the class 2, but for us it's over 30. And over 37.5 is morbidly obese or class 3 obese. So this discrepancy is brought about because of not only because of OHS, but because of the cardiovascular risk factors, the endocrine risk factors like uncontrolled diabetes and so on, and early deaths are more common in the obese Asians than in the obese Westerners. So that's why these figures have been kind of changed. So when you manage these patients with obesity hyperventilation syndrome, you can do your sleep studies, do everything, get them on CPAP, but you cannot stop there. Now that is the most important message that I have to give you, because the problem is not going to solve there. If the patient is class 3 obese, there is less than 5% chance of that patient responding to any other treatment of management of obesity other than bariatric surgery. I'm not saying this, these are proven, well-proven kind of facts. So because the weight will continue to increase, the BMI will continue to increase, you will continue to adjust your Cpap to BiPAP to and various other modalities, but the obesity will continue to increase. And in the end, it will be ineffective. And sleep and OHS is not the only thing which is going to kill the patient as well. It's the cardiovascular problems, the other endocrine problems, and so on and so forth. So you fail in your duty if you don't do something effective for these patients, especially who are in class 3. Class 1 and class 2, it's diet and medication. Right. So when the patients come to us, what do? We assess them and we get on with bariatric surgery. So what are these bariatric surgeries? Now, just to give a little overview, it's a change that we do to the upper gastrointestinal tract, which will in turn make the patient, one thing, lose their desire to eat more or hyperphagia, and then will lead to reduced intake of calories and in turn will lose weight in a natural and a permanent way. So there are several options that are available. We do first one is the sleeve gastrectomy, the commonest bariatric operation in the world. 50% of bariatric operations are these operations, but in my practice it's only about 25%. Because of a different reason. Now, we take the sac-like stomach, we convert it to a tube-like stomach. Now, everything else after that are bypasses. These are the two common bypasses. The Roux-en-Y gastric bypass, when you call gastric bypass, that is the bypass we are talking about. The gold standard bariatric operation, where we create about a 20 cc gastric pouch at the top end, and then and bypass about proximal 1/3 of the small intestine to achieve a malabsorption. Then a mini gastric bypass, when this operation is done with a single anastomosis, which is actually my most favorite bariatric operation. So how do they work? Apart from this calorie intake, it's by changing the neurochemical or the neurohormonal milieu within in the gut, which in effect affect your centers in the brain. So one of the key things that change is ghrelin. Ghrelin reduction, wherever we exclude the gastric fundus, in all bariatric operations, we prevent food coming and touching the gastric fundus. Gastric fundus has the highest number of ghrelin receptors in the body. And this ghrelin drive, as Amita said, is the one which drives your hyperphagia, the desire to eat more and more and more. So the ghrelin intake is taken out. Then we increase after bypasses, especially the GLP-1 levels and PYY levels goes very high. And the GLP-1 levels in turn kind of drastically start reducing all the absorptive mechanisms in the proximal small intestine, especially control the diabetes, which is an weight loss independent achievement of the gastric bypass operations. So there are so many, I can go on talking about that, but there's no time for that. But these neurohormonal or neurochemical changes of bariatric surgery are the ones which gives the biggest central effect on the obesity hyperventilation syndrome patients as well. The daytime wakefulness and the sensitivity of the carbon dioxide, the hypercapnia, to make this patient breathe properly it's a now well proven thing that it's a central mechanism that is brought about by the hormonal changes that happen after bariatric surgery. So, taking few examples of our own patients, 30-year-old male, BMI 48, or obstructive sleep apneic he was obstructive sleep apneic for years. When he came to us, uncontrolled hypertension. Now you can see the amount of central obesity, and this is within 48 hours we discharge these patients. Those are the only cuts that they get on their stomach. And this patient got admitted 1 year later for a different, in ENT issue, and you can see the complete different. Just look at his neck and you can understand how his obstructive sleep apnea or the obesity hyperventilation has completely disappeared. So And this is perhaps one of the youngest people that we have operated in Sri Lanka for obesity hyperventilation syndrome, managed by the respiratory physician of Gaul. I mean, they have done so much for this patient. Dependent on CPAP for sleeping, but the daytime hypercapnia was very severe in this patient. The patient could not move or could not work without an ambulatory oxygen device. That little bag is ambulatory oxygen device. And even just before surgery, you can see she came to the theater with the ambulatory oxygen device, planted in her nose. After bariatric surgery, all it took was 5 months to take the CPAP machine off. And of course, she has missed school a lot. I mean, normal development was not there in this child. She's schooling today, and she had a lot of other medical conditions. They also resolved by 1 year. So with 12 years of bariatric surgery at Colombo South and about 100 more cases in private sector altogether, about 500 operations, what have we achieved? These operations have become very safe, ladies and gentlemen. Today we follow the ERAS protocol, that is enhanced recovery, where these patients' hospital stay is less than 48 hours. Within 24 to 48 hours, we discharge these patients. Minimal analgesic requirement because only tiny cuts, and return to work is within few days after surgery. And we have analyzed data of each 100 patients separately, and they have been published, and we have been able to achieve the high volume bariatric or metabolic surgery status, where the morbidity and mortalities are extremely low in our hands now. So analyzing our own data, Chandimani has done this study. She has taken 13 patients of severe OSA as a preliminary study, and done objective assessment of the carbon dioxide levels, the lung functions, and the sleep studies. Then in 1 year has proven you can see the changes that has occurred in these patients, and this was published in Sleep Medicine 2017. And a recent study that this is about to be published actually, where we have analyzed 2 years between two operations, actually, the sleeve gastrectomy and the gastric bypass. In that about 200 and some odd patients, there were 59 patients with obesity hyperventilation syndrome, and the resolution of comorbidities. Just see the improvement and the resolution of the comorbidities. But when it comes to obesity, obstructive sleep apnea, that is obesity hyperventilation syndrome, this is very high in the ranges of 90. So this is, of course, clinical resolution. Chandimani is yet to do sleep studies on these patients to get me objective data on this group. But they are, large majority are not on CPAP anymore. So I think that's the message that I want to give you as a surgical perspective. So obesity hyperventilation syndrome, ladies and gentlemen, to treat or to cure. Now that is the matter here. You can treat it. You see, you can send him to dietitians, you can put the patients on CPAP machines, but this is a highly motile, is a condition with high mortality and morbidity, especially in young. So can you cure it? Yes, the cure is just a surgery away. So this is a 230 kilogram. Now you are wondering about whether we can operate this high BMI patients. Yes, 242 kilogram patient, which we operated at 230, about 240, I think. Yes, has lost over 100 kilograms. These are called the big losers in my group, and of course, completely cured with obstructive sleep apnea. So, if you want to know a little bit more about bariatric surgery or to explain your patients, the patient education website. www.obesitysurgerysl.com, and thank you very much indeed. Thank you.
Thank you very much, Professor Vijayaratnam, for your marvelous presentation. Our last speaker is Dr. Visira Sirinandana, who is the consultant ENT surgeon at District General Hospital, Trincomalee, and he is going to talk about ENT perspectives in sleep-related breathing disorders. Over to you, Visira.
you. Good afternoon, everyone. Thank you very much, Chair, for the kind introduction. And I'm honored to present in this distinguished gathering regarding the ENT perspective of sleep-related breathing disorders. So, what I'm going to talk about in overview, I would talk about why ENT surgery in sleep-related breathing disorders, and how do we evaluate. Obviously, now there have been several lectures talking about what is the sleep studies and everything. But when the patient comes to ENT, and what will be our evaluation process, and in aiming ENT surgical interventions, and how we manage what we want before surgery, before embarking on ENT surgery. And we will be talking kind of superficially on various surgical modalities available to improve the upper airway obstructions. So there will be soft tissue surgeries and implants, bony framework surgeries, right? So why do people come to ENT for surgery when they have obstructive sleep apnea? Sometimes we see that there's easily correctable anatomical deformities which causes the upper airway obstruction, and most of these surgical procedures had been done for decades now, but they were not aiming at sleep surgery. They were done for various other purposes, but later on had been modified as the sleep surgery evolves. So these surgeries had been there for ages, and all the ENT surgeons had been trained on these surgeries. So most of the time they are kind of easily correctable anatomical deformities, which will improve patients' quality of life. And there's another group of people who will not be compliant with your positive airway pressure measures, and they may be either use CPAP inadequately, or they may not be happy to use CPAP at all. And then there may be, especially in our part of the world, there will be cost concerns regarding the positive airway pressure devices and the maintenance. Right. So when a patient presents to ENT outpatient clinic with obstructive sleep apnea symptoms, or a patient referred to ENT clinic with obstructive sleep apnea features for ENT evaluation, what would we do in the beginning is obviously now the patient is, most of the patients are diagnosed with the other measures, which I'm not going to talk about. So we will assess patients clinically to correct anatomical deformities of the upper airways to enhance the physiological outcome. So clinical assessment include detailed evaluation of the facial anatomy, the maxilla, mandible, palate, and the tongue base and the pharynx. And this generally includes all the ENT patients will undergo some form of endoscopy, since we are looking into cavities. So during the endoscopy, we will assess the anatomy of the nose, the turbinates, the adenoids, and tongue base, and the epiglottis. So there's this maneuver which we all know about, which is called Muller's maneuver, which had been there for ages now, and it is something that we use to assess the functionality of the upper airway, and we try to mimic the negative pressure which is generated in apneic phases of a patient to see where do we need to do some intervention in order to correct or improve the upper airway. So in Muller's maneuver, what we basically do is we will ask the patient to keep a negative pressure in the nose and the pharynx, but without taking air in. So it will kind of it will kind of let the collapsible tissues collapse into the airway, and we can come to a conclusion. It's kind of a rough assessment as to where does this airway collapse. And then the more advanced recent development, which is called DICE, or drug-induced sleep endoscopy, and more anesthetists are more convenient with this, and more ENT surgeons are becoming convenient with this procedure. This is kind of more or less real time. It's not 100%, but more or less equal to real time evaluation of a patient who is developing apneic spells and snoring. So in DICE, the anesthetist will anesthetize the patient to a certain degree, monitoring through the BIS index to maintain kind of induced sleep of the patient. So as the patient sleep, it is not completely naturally, but it's more closer to a natural phenomena which happens with the patient. So there again, we will pass the endoscope, and we will have a look at the nasal airway, the palate, the pharynx, and the pharynx tongue base, and the supraglottic area. And that is kind of more practically relevant examination when we talk about surgery, or for us to plan further management down the lane. And there are imaging modalities, cephalometry and MRI. I think the other speakers also told about this. In cephalometry, it will give a kind of idea about how the bony framework of the upper airway looks like. And MRI will give you more about details of the soft tissues which can cause troubles with the upper airway and which can cause obstruction to the upper airway. And at the end of this exercise, we will try to determine where the problem is, whether it's in the container or the contents. Container in the sense that it is whether the upper airway bony structures causing the trouble, bony structures limiting the patient's upper airway, or else the contents by means of soft tissues and functional elements like soft palate and epiglottis causes any trouble to the upper airway and causing obstruction. So we'll be mainly looking at about 4 levels. As everybody knows, we are looking at the velum, oropharynx, tongue base, and epiglottis to determine the level of obstruction which can happen in patients with obstructive sleep apnea. And there's a good guideline or protocol regarding how to approach this kind of patients once we assess them completely. So there will be 2 groups of people who will respond to positive airway pressure, and there will be people who are not responding to positive airway pressure, or else they are not compliant, or they will be less compliant with the treatment. So as Professor said, obviously we might have to, especially if the patient is not improving for the PAP, or if the patient is not suitable for PAP treatment, we might have to consider the correction of comorbidities and correction of the BMI and the bariatric surgery aspect. And after that initial steps, we might look at we might do if that part is sorted, and if the patients are not kind of within the range for PAP treatment or bariatric treatment, or any want to enhance the outcomes of PAP treatment, we will go for this the container versus the content type of surgeries. So as I said before, we will be going for the physical examination, endoscopy, and drug-induced sleep endoscopy, aiming to determine which level we have the obstruction and which level we are going to correct. So then again, at the end of the examination and investigations, if we found out that it is the complete circumferential obstruction, or lateral pharyngeal wall causing the trouble. This patient might, or the dentofacial deformities, these patients might benefit straight away from the Stanford class 2 interventions, that is maxillomandibular advancement and other therapies. And if the patient doesn't come to that category, then there may be some correctable anatomical anomaly in the nasal cavity, palate or tongue base. We might be able to go ahead with a kind of intermediate type of surgery to get the patient's airway clear. So talking about the nasal surgeries which are available, and mind you, most of these surgeries had been there for many years, and now it's been slightly altered, slightly modified to suit the patients who need interventions for their upper airway and having sleep disordered breathings. So turbinate, one of the nasal surgery we do commonly is turbinate reduction, which will reduce the volume of the lateral wall of the nose, and it will improve the airflow through the nose. And at the same time, now those patients, some of the patients who are not very compliant with PAP due to the nasal obstruction may be more compliant after turbinate reduction. And then the septoplasty, it's more of a the nasal septum will come under both container and contents, because the nasal septum will sometimes reduce the nasal airflow, and that will the correction of the nasal septum, which is a very common surgery which has been done in ENT practice, which takes less than 1 hour, will improve the nasal airflow and outcomes with the positive airway therapy. And nasal valve surgery, again, that includes the lateral wall, the surgery to the lateral wall of the nose, as well as the bony framework. Under this category, we might be doing another type of surgery called septal rhinoplasty, where we might be altering the structure of the nose as well. And the newer version of this surgery, which is specifically came for sleep surgeries, which is called the dome distraction osteogenesis maxillary expansion devices. These are again not a big surgery, but it will give a big outcome for patients. And then when we go back to if we go to the palate level, the palatopharyngoplasty, as famous U3P or vulopalato-pharyngoplasty, and more recent lateral and anterior expansion palatopharyngoplasties. The other surgery available for this pharyngeal level is tonsillectomy, which had been there for ages again. And tonsillectomy combined with adenoidectomy has improved a lot of children from their breathing problems. And this is a very common thing done in Sri Lanka as well as in the other parts of the world. And going back to the tongue base, it's a bit of challenging surgery, and these tongue base reductions are more towards the sleep surgery, and these surgeries had not been performed frequently in the past, and now they are emerging as a part of our armory towards handling sleep disordered breathing patients. So tongue-based reduction, which can be done with the techniques available like radio frequency ablation and coablation, which are freely available in Sri Lanka and most of the places. And then the genioglossus advancement, that is you retract the tongue muscles forward and preventing it falling back into the airway and closing obstructions. And upper airway stimulation devices that are nerve stimulating devices which will stimulate the hypoglossal nerve to prevent tongue falling back or paralysis during the sleep of a patient, and it will keep the upper airway patent while the patient is sleeping. And myofunctional therapy, like in the means of tongue exercises, which are kind of non-invasive treatment that had been tried and can be done effectively. And as I said, maxillomandibular advancement, it's kind of vigorous surgery. I would say it might need some expertise, and we might need some help from the oromaxillary facial surgeons, because they are more familiar with the facial structure surgeries rather than the nasal, tongue base, and palatal surgeries. And having said that, even though we are thinking more of surgical aspects, before we cut, we will try various other methods. As I said, as we highlighted before, we might need to go for weight reduction and improve sleep hygiene, tongue exercises, and oral appliances, which will improve the patient's outcome. And those now I was discussing this. The surgery for contents are the turbinate surgeries, adenoids, the palatal surgeries, the tonsillectomies, tongue-based reductions, and epiglottoplasties or epiglottopexis, where the epiglottis can be moved forward, or part of the epiglottis, or the majority of the epiglottis can be removed safely and effectively to improve their breathing. And some of these surgeries are office-based surgeries. That means the patients will come the same day and they can leave the hospital same day. They like more of like daycare surgeries, and these surgeries can be done to the soft palate as well as to the tongue base. One of those surgeries is the palatal stiffening, where you can use radio frequency ablation to if the palate is more mobile, or if it is kind of lax, we can stiff the palate with the application of radio frequency methods. And tongue-based reduction, again, we can do surgeries to tongue-based reduction, like medium and lateral glossectomies, and even in the when the facilities are available, obviously not in Sri Lanka, we can go for transoral robotic surgeries, but that is only a small component. Those surgeries can be done even without the advanced technology when you are more familiar with it. And some of the tongue-based reduction even can be done as office-based procedures, like coablation and radiofrequency ablation of the tongue base, where you can reduce the volume of the tongue base and it will improve the volume of the upper airway. As you can see, the radiofrequency ablation had been there for quite a while now, and it had been proven to be effective in snoring and upper airway obstruction. And tongue-based channeling, which is coming as a treatment for sleep disordered breathing, which will, it's kind of you reduce the mass of the tongue by application of the coablation channeling, and that will reduce the obstruction which the patients have to their upper airways. And this is good old U3P, or uvulo-palatopharyngoplasty, which was the kind of surgery which had been done for many years now. So what in UP3, what happens is we remove the tonsils and part of the epiglottis, and we will expand the pharynx. This is the conventional surgery which had been done for snoring for quite some time now. But the problem with the UP3 is this: if you are not very careful, they can cause velopharyngeal insufficiency, which may be a even bigger problem for the patient. So now the tendency is to go away from U3P compared to the other surgeries. And expansion sphincter pharyngoplasty is another newer method of handling these issues, where we reposition the palatopharyngeal muscles and expand the oropharynx, so the patient's resistance to the airflow is less. And these are these, as I said before, these are small modifications which for the existing surgeries, where with a better outcome and less comorbidities. And upper airway stimulation devices which are coming up now, but at the moment we don't have it in Sri Lanka. But again, the device implantation is not that difficult surgery. And then stage 2 procedures, that is surgery for container. As I said, the septal rhinoplasty is again can be categorized into container problems, as you can operate there in the nasal valve and expand the nasal valve and reduce the resistance to airflow through the nose, which will help either primarily, or it will be adjunct to the CPAP treatment. So the patients patients are improving with these surgeries. And then the maxillary mandibular advancement, which had been there previously as a cosmetic surgery, and now it is re-emerging as a surgery for sleep disorders breathing, and with good defects. And the dome surgery and hyoid suspension. I explain about these surgeries later. So maxillomandibular advancement has shown a better surgical success rate. This had been the case throughout, and there are several meta-analyses showing that these surgeries has caused significant improvement in patients who are having sleep disordered breathing. In maxillomandibular advancement, what we might do is we will be dividing the mandible as well as the maxilla, and we'll reposition it in more anterior location, which will basically move the soft palate as well as the tongue to a better position to prevent upper airway resistance. This is the dome surgery, which is a new kind of surgery. That is, in this surgery, what we do is we will do osteotomies, and we will try to expand the flow of the nose by applying these kind of devices where the osteogenesis happens in the cuts and expand the flow of the nose, improving again the nasal airway. But having said that, earlier days we used to do, especially in children, when the patients comes to you with upper airway obstruction, they may have the narrow flow of the nose or high arched palate, causing the narrowing of the airway. But as we do adenoidectomy or tonsillectomy and improve the airflow through the nose, the changes which had occurred before tend to revert. But this surgery is again, especially in adults, so you can implant devices and along the midline suture, and then expand the flow of the nose, which will improve the nasal airflow, and it will improve the nasal valve function, and it will reduce the upper airway resistance. And the thing that ENT surgeons can do, especially now patients, some of these patients, as we discussed before, might not be benefit from all these procedures, and they may be having kind of morbid obesity and conditions like that, which might need some time for correction before we embark upon other treatment like CPAP or else the bariatric surgery, and the patient needs to be operatively optimized to go for surgery and to improve their lung functions. In that kind of situations, we might be able to perform tracheostomies and eliminate the upper airway resistance completely as a temporary measure till we gain the control by other means. Right. I would like to thank Dr. Damindu Domingo Arachi and Dr. Chandra Jayasurya, who are kind of pioneers in sleep surgery in Sri Lanka. They brought this thing and they highlighted this thing again and again. Thank you very much. Thank you. Thank you.
Thank you very much, Visira, for your nice presentation. Unfortunately, there is no space for questions as we are out of time. Therefore, I invite Dr. Ravini Karunatilaka, President of the Sri Lanka College of Pulmonologists, to hand over certificates to speakers. First speaker, Dr. Samanmali Dalpadatu. Dr. Dilesh Avadasinghe. Dr. Damit Rodrigo. Dr. Kishar Gunaratnam. Professor Tejana Vijayaratnam. Dr. Visira Sirinandana.
Thank you very much, madam. So that brings us to the end of this interesting symposium. So I would like to propose a vote of thanks. I will, on behalf of the Ceylon College of Pulmonologists, I would like to thank the Sleep Assembly, Chair and the members, and Dr. Uppul Pathirana for organizing this symposium, and all the speakers and the attendees, and all of you who contributed. Thank you very much.